It's all in your head. You don't look sick. Your tests are normal. It's probably anxiety. There's nothing wrong with you. Have you heard these words from physicians, family, and friends? If you're someone who has been struggling and swirling through the revolving door of healthcare to find answers about your health, or if you know someone who is going through this experience, then this podcast is for you. Welcome to the Desperate for a Diagnosis podcast with Laura Nozica, a show dedicated to exploring the challenges of living with undiagnosed or rare medical conditions. This podcast explores both sides of the bedside. We will be speaking with patients who have had challenges with finding a diagnosis, along with experts in the field. I'm your host, Laura Nozica. And welcome to the Desperate for a Diagnosis podcast. I am your host, Laura Nozica. And today I have a return guest I have a guest who comes back a second time. I consider that guest a friend of the show. So I have a friend of the show here, and we have Dr. Alan Rapoport with us again. And for those of you who reviewed or took a gander at our podcast episode about headaches and doctor's background in headache medicine, he is a rock star in the field, and I welcome him back to the show. Dr. Rapoport, thank you for being here.
Thanks. I enjoyed the first round with you, and I'm sure I will enjoy this one.
Well, I sure hope so, but I would like to make sure that folks know who you are, who again, listeners who might not have listened to our previous podcast, I'd like to introduce you again so they know about your such impressive credentials and all the work that you've done in headache medicine. And let's just do a little review of your bio and we will get started in our conversation. So here we go. Dr. Alan Rapoport is a clinical professor of neurology at the David Geffen School of Medicine at UCLA, Los Angeles, California, where he teaches medical students, neurology residents, and fellows. He is a past president of the International Headache Society and the founder and director emeritus of the New England Center for Headache in Stamford, Connecticut. He is board certified in neurology and headache medicine and the fellow of the AAN, and he has co-authored more than 350 articles, chapters, and posters on headache and other neurological diseases. He has lectured around the country and internationally to general physicians and headache specialists and has appeared many times on national radio and television programs such as Today, CBS This Morning, and Good Morning America. So not only is he a rock star in the field of headache, he is also a celebrity. Who knew? Dr. Rapoport, very, very impressive. He has also been the editor of Headache, CNS Drugs, and editor-in-chief of Neurology Reviews. He reviews for many peer-reviewed journals such as Cephalalgia, Neurology, New England Journal of Medicine, and Headache, and he has co-authored 9 books on headache for patients, physicians, and nurses with Drs. Fred Sheftel and Stuart Tepper. He is the co-founder and CEO of Bone Triage, not bone like one bone connected to the other bone. I won't sing, but Bone, Bontriage. Very French of you, doctor. I do enjoy the name of your company. Bone Triage, a medical IT company in Silicon Valley, California, dedicated to helping patients and doctors around the globe by collecting detailed patient histories online using AI and shortest pathway analysis technology and linking them with a new app named Migraine Mentor, which monitors patient progress and outcomes. The company has started with headache and is moving into Alzheimer's disease, sleep, depression, anxiety, chronic pain, and other areas. Dr. Rapoport has served on the board of directors of the American Headache Society and is the immediate past president of the Fairfield County Neurological Society in Connecticut, the founding president of the Headache Cooperative of New England, the founding director of the Headache Cooperative of the Pacific, and he has been the director of the Headache Day at the annual International Controversies in Neurology for 15 years. My goodness, Dr. Rapoport, the energy that you have just pales any energy that I have these days. How do you
Well,
do it?
I'm very young,
You
so
are.
that explains it all. And I do go jogging every day, and I suggest to all your listeners that they exercise on a daily basis because it's essential.
No, it's so important to do that, and you must have started medical school at what, like 12? My gosh.
13. No,
14, okay.
I went to college at 16, so I am kind of young for my education, but
Oh,
when you get to my age, it doesn't really make too much difference. And
but you were kind of the Doogie Howser then of
yeah,
headaches.
I was a young guy. They used to say, "Send in the real doctor." When I was an intern and resident at Mount Sinai in New York, they would say, would you send in the real doctor?"
That's funny because, but you know what, doctor, I'm getting old enough now here at 54 where I'm thinking those things myself these days.
Yeah, they look
Where's the
young, don't they?
They do, they do. I look at them and think, "Are they old enough to drive?" You know? I sound like that old lady now. It's so true. It's so true. I know. But Dr. Rappaport, I'm really flattered, I will say, that you are willing to come back on my show and have us talk about a topic that I think it's an important topic, particularly to patients, but I think this will be an interesting conversation for physicians as well. And it's not something that it has been talked about a lot, certainly in the media, and there's articles out there. But the conversation that I'd like to have with you today, and actually excited to talk about, is the topic of medical gaslighting. And again, I'm looking so forward to hearing your perspectives on this topic because it is something that I have heard many, many times from not only my podcast patient guests, but also, as you know, I conduct market research and moderate market research for a living, and I have heard these terms from those patients as well. So I'm so honored that I'm able to talk to a physician directly about this topic. And medical gaslighting, again, is something that I have heard about for quite a while. And because it kept coming up in my conversations, I wanted to do more research on what it is and what it means. And like I said, I have been reviewing some articles about the topic. And I came across an article through the Scientific American, and the article was also published on a website called The Conversation just last year. And according to this article, the way they talk about medical gaslighting is that medical gaslighting refers to cases in which a healthcare practitioner imposes a pattern of questions, testing, or diagnosis that runs counter to the history or symptoms of the patient and how they're describing of what they're describing or what they're experiencing. And there's a lot of conversation about how medical gaslighting is very prominent with women, with people of color, with maybe older adults. And a lot of times patients walk away with feeling like doctors believe that what they're communicating in terms of symptoms, et cetera, are all in their heads. And so, whether or not that's the actual definition, I think it's an interesting idea and concept, again, given because I have heard it from so many people. So I just like to toss it out there and kick off our conversation and get your thoughts on that line of thinking through this journal here, this Scientific American, and what you think about it. We'll get more in depth on different examples and maybe some other thoughts about it.
I haven't read the article, but I can tell you that Scientific American is a wonderful, wonderful magazine or journal. I don't know if it's peer reviewed, but they get very good people writing articles, and they wouldn't put anything in there that didn't have some truth behind it. And I don't use the term, and I don't usually hear the term gaslighting of patients, but I would say what would fall into that category would be if a patient leaves the office and they're unhappy about the history that the doctor thinks he heard when he took the history, or the diagnosis that the doctor made, which runs counter to what the patient thinks is wrong, or the treatment that the patient is getting, or suggestions that maybe they go to another doctor or to a psychologist or to a psychiatrist when they're really coming in for help. That's what I think this term means. And I will simply say at the beginning, in defense of some doctors, it's more difficult to practice medicine today than it was when I started out 52 years ago in my office, because back then I worked for myself. Most neurologists like me worked for themselves. Some of them were working in a hospital, but most of them were in private practice. And if a patient ended up in the hospital, they would go to the hospital to see the patient. Today, probably 85% or more of neurologists are working for a big corporation. That could be the hospital. They
Mhm.
could be employed by the hospital. It could be a private corporation in business to make money that bought the doctor's office or bought a whole healthcare system. And I'm not saying that that by itself is wrong, but it puts the doctor into a funny situation where the doctor's not working for themselves anymore. They're 9 to 5, some of them. At 5:01, they want to be out of the office because they're only paid to be there till 5. They have to see a patient in a fixed amount of time. Neurologists have a very difficult job, and most of us, when I started out, spent 1 hour taking a history, doing a physical, talking to the patient, making a diagnosis, looking through their lab stuff, and giving them treatment advice and setting up scans and so on. That hour isn't even enough time. But today, your doctors, if you're going to a general physician, has between 8 and 12 minutes to do all of that, and they don't have the expertise. Like, I'm a headache specialist. They got very little information in medical school about headache. They read a little bit about it, but they have to read about every organ in the body, so they don't really know that much about headache. You come in with a headache. Some of them, especially if they're older, they're thinking old think that somebody with a headache has psychological problems, which is almost never true. Of course, it's sometimes true, but it's not usually true. And they're looking at their watch because they got another patient coming in another 3 minutes. So, and they have to either type out or dictate a report on this patient. And they got to talk to their staff so they can say, please get this scan or do that blood work or whatever. So, in defense of doctors in general, they don't have it easy anymore. I'm not saying they don't make a good living. They do. I'm not saying they get home at 5 o'clock. They may stop at 5 and have 2 hours more with the medical record that they have to fill out. I just read an article about how long it takes each type of doctor to have to spend time after they're
Mm.
finished with their day. You think
Interesting.
everything's done, they usually have to do a lot more with the medical record. So, with that as a background, doctors have different personalities. And I think if a patient leaves unhappy, it probably has something to do with the doctor is looking and feeling like they don't have enough time for the patient, because that's kind of true. And they should try to make the patient feel a little more comfortable, but it doesn't work out so well. Certain doctors I would say in general, surgeons are more like this than medical doctors that don't operate, but there's always exceptions to everything. They want to say, this is what's wrong. This is what we do about it. Goodbye.
Mm.
They might say, I think this is what's wrong. And this is the best way I believe to get this taken care of. Do you agree or not? Or what do you say? Do you want to discuss it at all? But the good doctors, in my opinion, will say, look, I hear what your history is. I've examined you. And my feeling is you could have one of these three things, and it could even be something else. I want to do some testing. And here's the testing that I absolutely want to do. And here's things we might leave for later if we're not getting any answers. And I might want to start you on something today just to see if it works. Or I really don't want to start you on anything today because I want to know what's wrong with you. And I got to make a good diagnosis first. And here are the types of treatment that you and I are going to discuss. And you're going to choose the one that's right for you. Now, it takes longer to be like that, and it takes a certain personality to be like that. And most doctors aren't like that. And I just happen to be like that. And that's why more often than not, patients like me and don't want to leave me because the doctor they came from before they came to me pretty much dismissed them out of the office. And so I find myself too busy because I listen to patients and I like to discuss with patients, but that takes time. And I'm very fortunate because I still work for myself after
Mhm.
52 years.
Wow.
I take
Congratulations.
I take an hour to an hour and a half with a new patient and a good half an hour with a patient coming back. And doctors can't do that. They just can't do it. So I feel bad for the doctors and I feel bad for the patients that go to them. And I think what you'd find if it were a headache problem or any other neurologic problem, the doctors that are really super specialized, they're going to take more time with the patient. And the reason is because the other 5 doctors that they went to couldn't figure it out. So you need to spend more time taking the history, and uh, discussing things with patients so you get to the right answer. Now, here's a place where my company actually does come into play because we set up this company, Bone Triage, to help this situation by having a patient go online before they go into the doctor and take their own history online in a very comfortable situation where they answer a lot of questions. It's not going to take 10 minutes. It might take 45 minutes or an hour if they haven't bad enough problems and answer all the questions that I would have asked that their doctor won't have time to ask or the expertise to ask. They answer all of it. We can't make a diagnosis if we haven't seen the patient, but we come very close to the diagnosis that we're suggesting. And so they can bring that report into a doctor, and the doctor has a huge head start. They can put that in their medical record. They have a better idea from an expert what the problem is. And this is the way of the future. This is artificial intelligence for the future. And I started my company over 10 years ago. And so we were way ahead of the curve. The problem is that
Way before anyone knew what
nobody knew what
people knew
AI
what
was.
they may have heard of it in some sci-fi movie or something like
Right.
that, but it wasn't mainstream vocabulary like it is.
Right.
Oh,
And the reason we started it is exactly for this problem. My partner and I started this. He's a professor at Stanford University and I'm at UCLA. We looked at each other and we said, there's 60 million people in the United States with headaches.
oh.
and there's 300 doctors specialized in headache. There's no way you can get to see us.
There just aren't
You
enough.
can't even you can't even get in to see a neurologist sometimes, right? You go to your general doctor and it'll take 2 to 3 years before you get referred to a neurologist.
Yep.
So we said, we have to do something with computers, which everybody is starting to have 10 years ago now. Everybody has, and make it easy for the patient and the doctor they bring the report to. I don't want to spend a lot of time on that, but these are the problems. And so when the patient leaves unhappy, there may not be anything they can do about this. You know, they could go back next time and say, "Doctor, you didn't spend that much time with me. That's not good because she only has X number of minutes. You said I had a diagnosis and I didn't completely agree with it." Some doctors will be upset with that. Some doctors will say, "Well, why? What do you think?" I like to ask my patients, "What do you think is wrong?"
Oh,
Because patients are very smart, and your ability to feel things in your body and to kind of know what's wrong is really helpful. The problem with it is everybody reads too much on the internet. And before they go to the doctor, 75% of people look something up on if Google is actually pretty good. They might look it up in the wrong place
yeah.
and they come in.
Or now, doctor, they're putting in prompts on Chat GPT to figure.
Oh, absolutely. And by the way, that might work.
Yeah.
But if it doesn't work and they say to the doctor, "Look, I went to so and here's what I came up with," doctor's not going to be happy with that either. I would be happy with it because if it fits what I think the patient has, I'll say, "Boy, you really went to the right place. This is probably what you had." If it doesn't fit, I would handle it slightly differently. That's a possibility. I don't think it's the right one, but we're going to consider both of them and do the appropriate tests to figure out which one it is. So, anyway, some doctors you're just not going to get anywheres with. And if they come up with stuff that you don't like, you should try again, but it may not be pleasant for you. And it may be time to look elsewhere. And it might be a doctor that you've been going to for a while. And I don't like to suggest leaving a doctor, but sometimes it's appropriate.
Sometimes it's run its course, which I get personally. I think everyone has been through a situation like this before. I've had my own where I've seen a neurologist for a what seemed to be a muscle issue, and I had a head twitch and some very bizarre symptoms. And I had one tell me that I had cervical dystonia and should get treated with Botox injections. And I said, well, that doesn't sound very fun. And not everybody, I'm certainly no doctor, but I've spent so many years in healthcare where my spidey sense said, let's wait on that. And I saw another neurologist and she agreed that it was cervical dystonia, but she said, don't treat it with Botox because you can cause more problems than what you have now, and that it's so mild and that I should just live with it. And I think a lot of patients hear things like that too. Just live with it. Well, I don't take just live with it for the final answer. And I kept going. I saw a physical um, rehab medicine physician, and he wanted to do some injections in my neck to kind of see what's going on in there, and let's try to maybe reduce some inflammation. I had a physical therapist and a sports medicine doctor said that they didn't think it was cervical dystonia, and gosh darn doctor, I don't think it was because with physical therapy, a lot of it, I don't have those symptoms anymore. So I kept pushing though, and yet there's so many patients that push for answers and they go through that what I call the healthcare revolving door, and they've seen so many physicians, haven't been able to achieve a diagnosis, or if not a diagnosis, some resolution to their symptoms. And by now, they're frustrated, really frustrated.
That's the key, resolution. When a patient comes in to see me, the average neurologist with the same patient would say, I think you may have this. Let's do these tests. Tests come back negative. They say, I don't find anything wrong. Goodbye.
Yeah.
That's what most doctors do. The way I look at it, I don't find anything seriously abnormal, which is a good thing because serious abnormality in the brain is not a good thing. We
Right.
don't always we're not always able to fix it,
Right. So you know
but
it's not the bad stuff, which is a good thing.
it's not the bad stuff.
Yeah.
But I want to try to help you. And we could try this or that. But I know people that do other things like biofeedback training or physical therapy or Botox in some cases where it might be appropriate or whatever. But I don't rest until either I help the patient or the patient says, I don't think I'm getting anywhere. I'd like to go to someone else. And I don't mind that. I like it when a patient says, I'd like another consultation. And I'll say, okay, let's talk about that. And I know a lot of doctors all over the country, and some of them are smarter than I am, probably. And I don't mind if a patient goes there and then they can come back to me if they want, or they can stick with the other doctor. A lot of doctors aren't like that and they get upset.
Mm.
And unfortunately, in my situation, since I'm kind of a super specialist and the patients have been to 7 doctors before they come to me, if I say to them, I want to get a consultation, they think I'm trying to get rid of them. And I say to them, and they sometimes express that to me. I said, not at all. I'm looking for help to help you. You come back to me. If you want to stay with the other doctor, that's fine, but I want you back. And then they feel much better about it because they figure if I don't know, nobody will know. And that may be true, but it's not always the case.
Yeah.
So when I need help, I'll say it to the patient. But most doctors don't suggest that you go to um, another doctor. I think you and I talked about this once before. When I was practicing in Connecticut, there was a very good doctor who liked me and I liked him, but he would never send me a patient. But he was a general neurologist and he did everything. And I was a more of a headache specialist. So when the patient had headaches and he wasn't helping them, they might even say, can I go see Dr. Rapoport in the next town? Because he's a headache specialist. And they often said, well, I know Dr. Rapoport. He's a great guy. He really knows a lot, but I know a lot about headaches, so no reason to go.
Oh.
And then the patient would come to me on their own after a period of time. Sometimes I get them better in 2 months. And they'd say to me, and they'd switch to me and they'd say, why didn't Dr. X send me to you? And I said, look, he's actually a very good doctor, but he thought he could help you. And at some point, you realized he wasn't helping. And so, he wouldn't have sent you to me. So you made the right choice in your case. So every doctor is different. And some doctors are very territorial, isn't the right word, but they want to hold on to their patients for whatever reason. And
Well,
some doctors,
I'll just put it out there, doctor. How much does ego get in the way?
a lot.
Say for you.
Yes.
How much does ego
They're
get?
born that way. They're born that way. It's their mother's fault.
Blame it on the mother, right?
It's always the mother.
I tried my Brooklyn accent there, or maybe that was Jersey. I
That
don't
was
know.
pretty good. It wasn't perfect, but it was pretty good. But by the way, when patients come in to me and I diagnose migraine, which happens a lot, they say, doctor, where does this come from?
Mhm.
I said, you got it from your mother because it is somewhat inherited migraine. And it could be from the father, but it's more likely to be from the mother. And women have migraine 3 times more than men, like we talked about the last time. So you probably got it from your mother. And I have many patients where I have the mother and 1 or 2 daughters, and sometimes a son. because if the mother does well, they want to send their kid to me as well. And it does run in families. So it sometimes does have something to do with the mother.
Yeah. Yep. And there's so many things too, doctor, is and certainly beyond just neurology, but there's so many instances where a patient comes in with symptoms. And again, I've been through this myself. Let's just take fatigue, for instance. Fatigue could be 100 things on, as doctors likes to refer to the differential, the list of all the possibilities. It could be 100
100 things.
things. Yeah. Yeah. So then you're really in a bind, kind of in a pickle at that point as to even where to start.
Yeah. And, they might ask a neurologist about it. And we know something about fatigue, but it's not usually in our specialty. And it could be due to any number of diseases. The first thing I think of is thyroid. People with a low thyroid, and a large percentage of the population will have a low thyroid sometimes. And you boost the thyroid to normal, and the fatigue goes away. Serious diseases cause fatigue. And there are many other things that a patient has as a diagnosis, which could also cause fatigue. So you have to kind of figure out what the bottom line is with them. And then, of course, it could be something simple like they go to bed at 1 in the morning, get up at 4 in the morning.
Well, it's being a rock star, yeah, but it's true because, and again, going even back to my example where neurologist number 2 said, I think you have cervical dystonia, don't do Botox, live with it. You'll end up with more problems if you do Botox. And I had come back to her a couple weeks later because I had a lot of muscle pain, spasms with this head twitch and this right side weakness that I was experiencing at the time. And yet it was resolving a little bit with physical therapy. And then she had said, I don't think you have cervical dystonia. I think you have muscle imbalances. So continue physical therapy, but I think you also have anxiety. So treat the anxiety. Well, I was anxious, yes, because I didn't know what was going on with this head. It was a head twitch, and it would happen several times a day, just a very slight little twitch, but it was enough to where I couldn't hold my head midline and my head liked to hang out towards the left. I think that's why they thought I could have had dystonia, but she mentioned anxiety, and I think that patients do either get an inkling that a physician thinks that, and here I'm talking to a neurologist, but where they think the doctor's saying, "Oh, it's all in your head," air quotes, all in your head from a psychological standpoint, and and they walk away with that when they don't have answers, and I don't know if that's really something that's happening that doctors are telling them, or they're suggesting maybe you should get therapy for whatever it is you're going through. And then patients don't walk away saying, "Well, my doctor totally dismissed my symptoms and he thinks I'm crazy." So these are things that I have heard from other patients too.
I would say, believe it or not, when somebody comes to see me with any neurological symptoms, over 50% of the time, I don't find any illness.
Mm.
I don't find a tumor or epilepsy or Parkinson's or any illness,
MS or anything.
MS. And I might even do a scan of the brain to make sure there's not a silent brain tumor or something like that, or a little stroke that didn't produce any evidence of it. And at the end of the workup, I say to them, look, I didn't find anything abnormal. That's a good thing. I want you to smile when I say that because it means you don't have a brain tumor, you
Yeah.
don't have MS, you don't have a stroke, but you're not feeling well. So let's treat the symptoms. And I have an advantage because in headache, one of the things that I like to order for people, I could do it myself, but I don't have enough time. So I get a specialist to do it, is biofeedback training. And it's done by a PhD psychologist. It could be done by somebody right out of college or somebody with a degree that isn't really a medical degree. I mean, they might have a medical type degree, but they're not a DO or an MD or so on. And but the good ones that are very well trained in it are really good at it. And even if I thought there was some anxiety there, I don't even have to bring that up to the patient because when they go to see this person, he or she is going to take a history and may come up with some anxiety as one of the diagnoses and may say to them, look, you're a little anxious and you're certainly anxious about this problem you have. But when I treat you physically with the biofeedback training, it's going to help your anxiety as well.
Mhm.
And so it was easier for me not to have to say to a patient, I think it's all in your head. I want to send you to a psychologist. They don't like that. But if I say to them, I don't find anything seriously wrong, but this technique will help physical things and even some anxiety. So if there's an anxiety component to this, it's still going to help you. And you don't need long-term care or anything like that. You don't need medication for it. Now, the other interesting thing in headache, a lot of our older headache drugs are actually drugs used for things like depression and anxiety.
Oh,
And so I would have to explain to patients when you look this up, or if you go to the pharmacist, they're going to say, "Oh, you're depressed." And what we do in certain types of headache, we know that the serotonin levels in your blood and in your brain are low. We want to boost them. The best thing to boost them are certain types of antidepressants. So I'm not saying you're depressed. You may have a little depression, but I'm treating you to raise your serotonin levels so your headache will get better.
yeah.
Lately, we have newer medicines which don't work on serotonin. So I often don't have to even get into that conversation. But I like to explain to patients why I'm giving them a certain medicine because they're going to look it up and think I'm not telling them
Well,
the truth.
they're gonna look up that SSRI and wonder why they, are getting that class of medication, but it's true, and who knows, like I said, even in my situation, sure, I was very anxious because for months I suffered with this pain, and it took a long time to get in to see a physician, a specialist, and I'm walking around thinking because I am Googling our Dr. Google too much. There is something to be said for too much research. And I'm walking around telling myself I probably have MS, which luckily I did not. But patients do get themselves very whipped up and anxious and feeling like nothing's working, nothing's helping. And again, it's just this revolving door of physicians. In fact, one of my previous podcast guests, she was so sweet, and she was dealing with, she had a diagnosis, but she couldn't, for the most part, but she couldn't get any treatment for it, and she was dealing with, I believe, some connective tissue disorder, which is sort of kind of vaguish, kind of, broad thing. POTS as well. So a lot of these things she was dealing with, but just could not find any resolution to these symptoms. And she had said to me, well, I was on I don't know what number doctor she was on her way to see. And she said, I did my research, but I wrote my questions down. I wrote what I thought were really smart questions. And I didn't do too much Googling. She said she was Googling responsibly, which was an interesting comment. And she said, and I dressed nice. I thought if I dressed nice, the doctor would be more likely to help me. And this is how this guest it was viewing her experience with the medical system, that she had to dress a certain way, be all buttoned up with her questions, etc. And then unfortunately she got in front of the doctor and she knew that she was under a time clock and got all nervous and kind of got the white coat syndrome and walked out with really no answers versus even besides answers that she wanted. But she was totally derailed with time constraints. So it is very difficult for many
Yeah,
patients.
that happens, and then what you have to do these days is you have to go to my chart on the computer and ask a question. I have to do the same thing. I can't get my doctor on the phone, even though I'm a doctor
Holy
working in the
cow.
same hospital.
Well, if you
I
can't get to the doc,
Nobody can. You
we're
can't
all in
get the
trouble.
doc you can't get the doctor anymore, but I'll tell you what I do, which everybody recommends don't do it. My patients all have my email address.
Mm.
And I don't get bothered by them, but if they're in trouble, and I travel a lot, as you know, and sometimes I'm in a totally different country and I get an email from them and I answer it right away and I
Wow,
tell them what to do. And I don't charge for that.
that's
Doctors
incredible.
don't do it and they charge for it,
Yeah. Yeah.
both of which I think are wrong because I know myself, I can't get in touch with the doctor. So I put down my thing and it says, your doctor will answer within 48 hours business days. So if it happens to be a Friday, that's a Monday.
We're done. Yeah,
And I could be dead by then, you
it's
know?
true.
And so it's a totally terrible system we have right now. We shouldn't get into that too much because I don't know how we're going to fix that. But it's a bad system. And luckily, I don't do it too often, so the assistant in the office does speak to the doctor, and I do get an answer usually the same day. But I once had to leave a doctor because my wife and I were patients of a doctor who was a great guy, but his office was terrible.
Mm.
Those things happen. They were terrible. And I was out of town, and my wife called me and said, "I have severe pain in my abdomen." My wife doesn't ever complain.
Mm.
So I said, "Call the office and tell them I said you have to be seen." And they say, "Well, we don't have any appointments today." And they said, "We'll call you first thing in the morning." And they didn't call. And I immediately left that doctor's office because you can't practice medicine that way. Now, the problem today is what they do is they say, well, if it's that bad, go to the emergency
Or it
room.
would be ER. Yep.
And you wait 2 hours and the doctor's rush and
If you're
take care of
lucky.
heart at,
If you're
yeah,
lucky,
if you're
doctor, 2
lucky, if you're
hours,
lucky.
that's pretty good, yeah.
And the doctor's rush and they're taking care of heart attacks and strokes and car accidents. And they don't often make a good diagnosis or know what to do about it. And then they give opiates or something, which is totally inappropriate. So I don't like the system, but let's not get into that because we can't fix that.
Yep.
But doctors can be better. And if you're having trouble, with your doctor, you have to either talk to them about it or you have to leave and get somewhere else. I remember just a few patients who would always take twice as long as another patient. And I didn't know what to do about it. And they had to pay me per visit. They had insurance, but they had to lay out a certain amount of money. But finally, I said to them, look, you take twice as long as everybody else. I don't have a problem with that, but the next patient waiting in the room does, and it makes me run late. If you want to pay for 2 visits, I'll spend 40 minutes with you. If you want to pay for one, I'm going to kick you out after 20 minutes. But most patients would love 20 minutes
Sure.
on a revisit, right? And no patient ever argued with me about that because it was fair. And some of them said, I want the extra time. I'll pay for it. Fine. So we booked them for a double booking because patients don't realize we do have 20 patients sometimes in a day. And as soon as they run late, and I take as much time as I need with each patient, but if they're constantly needing more time, they're going to make everybody late. And
Yeah,
that's not a good thing.
there's definitely a lot of trade-offs there, because there's been times where, yep, I've been late for an appointment and for whatever reason, and I get there and I was 10 minutes late and I was turned away, which I think is is difficult for a patient to wrap their brains around, especially when patients will sit in a room like your example, or sit in the waiting room for 45 minutes or an hour, whatever it might be. And so a patient's time isn't valuable either, but it is what it is. And so patients do get very frustrated with just the inner workings of an office, or they don't understand them. And I don't know that they really care how an office works. All they want to know is that they get to see the doctor, and they need to take the time to lay out all their issues. And certainly sometimes we tell more details of the story than doctor needs, which is maybe something that, like your assessment, your tool that you have just from a headache perspective, but just in general, how can a patient better prepare for an appointment with a physician, and especially if it's a new physician that they don't have a relationship with? How can a patient prepare for a visit with a new physician so that they're not taking so much time or embellishing on the details? Not that that's not important, but getting to the main part of the story.
Well, you're gonna like this. I would direct a direct answer for you.
Love it.
So my system has been the same for 10 years, but we keep improving it, making it better. But it's the same general idea. And then we realized that the question you just asked is vital to a patient. So we are changing the system. So at the end of the report that you get as a patient, and this is on headache right now, but we're going to other disease states.
Yep.
It's going to give you the 3 or 4 questions based on your symptoms and what you told the computer to ask the doctor. So I only had, we're testing it right now, and I didn't realize you were testing it. So I read one of these. I'm going to talk to this patient on Wednesday, and I saw it, and it said, when you go to see your doc, and they didn't know that she was coming to see me, but when you go to see your doctor, you might ask them, is there a medicine that would work faster on my headaches? Or is there something I can take on a regular basis that will cut down on the number of headaches I have? Both of which I would ask the patient. But if they're going to a general doctor who doesn't have time, wouldn't that be great to ask doctor questions that make a lot of sense? So we put that into the computer. That is a very important thing. And if you're not having headaches and you don't fill out the bone triage assessment, I think it's appropriate to have a few questions on a page. But if you take out a page of 12 questions, it's going to make any doctor nervous, even me.
Yeah.
And they may all be appropriate questions, but after my taking a history and doing an exam, and I handle 12 questions. That's, the question. So if if the patient's going to make a list of questions, either keep it shorter or put the most important questions first. I don't have a problem if they want. I always ask, do you have any questions for me? But that's after I go through an explanation of why I think from my history that I took and the examination that I did and looking over your lab work, why I think you have this diagnosis, or it could be this or this or this. And I want to try to help figure that out. And then if they have questions, I always ask, do you have any questions for me? And if they say, well, if it's this, what do I do if it's that? I say, well, hold off. Let's figure out what it is, because I don't want to answer for 3 things that you don't have. And they're okay with that. And I say, don't worry. Once we make the diagnosis, you can ask your questions about that one. And treatment, I'm going to discuss with you. I'm not going to tell you you need this or that. We're going to talk about what you want. Some people, after getting 2 or 3 types of medicine and having side effects from all of them, when I say, okay, I want to try you on this medicine, wait a minute, I don't want any more medicine. What else can you do for me? And I have a lot of other answers. I can give them vitamins, minerals, herbs, biofeedback training, physical therapy. I got a lot of other things to talk to them about. So I always say, what do you want? And most doctors don't do that. They tell the patients what they think they want. And that's not a good thing.
Mm.
But you probably have other questions.
I could ask you questions forever. I could be one of the patients that come to you with the 12 questions or even more. But it, as far as patients coming in with questions, et cetera, from the standpoint of, they're digging for answers just as much as I would like to think physicians want to help dig for answers. But what are your thoughts, doctor, on you talked about physicians who might be employed with big medical groups through whether it's through the hospital or whatever privately owned medical group as well, and they're faced with a patient that has these mystery symptoms, and maybe the doctor will start with process of elimination. Where do you think the doctors, I guess, how do doctors find the time then to really do research on the patient's symptoms or what else could be going on? Do they do it? Do they have time for it? Like you said, there's doctors who are employed and it's 501 and they're out the door. So how do patients work with a physician or find a physician who wants to be collaborative in that it's not just, okay, I'll send you for all these tests. And if we find that if there's no findings, okay, well, then we got to figure out what the next thing is. How are they going about finding the next thing, or where do they have time, or what's
So
who's doing at that point?
the answer is very variable. But what I do more often than not is if there's one or two symptoms that the patient has when it's not fitting in, if I know a lot about that symptom, I don't have to dig too deeply. I can say to them, there's three other things this could be. But if I don't really know enough about it, I will either go to the literature myself and do a little digging,
Mm.
not right then because I got another patient waiting, but I'll be interested in doing that. And by the way, when I teach at a hospital with a resident there, this happens a lot. And I say to the resident afterward, we really don't understand what's going on. I want you to look up these two things and maybe you'll come up with a diagnosis or a treatment and then you'll let me know. So they'll do the work for me because that's part of the teaching. But if I have to do it myself, that's fine. The other thing I do is I ask another doctor that I know. And that could be a doctor in my office. It could be another doctor at the hospital. It could be an email to another doctor. I constantly send emails and occasionally phone calls to people that I know elsewhere in the country, elsewhere in the world, and say, I got this really interesting patient that I can't figure out. Here's the story. What do you think? And they'll have three or four suggestions to me, either how to find out or they may even have a diagnosis that I haven't thought of. But not every doctor is going to do that. And, you're kind of stuck with who you have. And if the doctor isn't really interested in helping, it's sad to say, you're not going to get much out of them. I mean, I've been personally to doctors that I don't think they really knew too much. And if I ever got sick, they'd refer me to a specialist in that category. Like if my thyroid wasn't working, they'd send me to an endocrinologist. And if I had chest pain, they'd send me to a cardiologist. The days of the grand old doctor that really knew a lot about their patients and really tried very hard to figure it out are pretty much gone. I know a few of them. I don't know them here in LA, unfortunately, and most of them have retired. But that's doesn't happen too much anymore. It's kind of sad. So you're dependent on when you go to your doctor, you're dependent on the doctor's personality and ego, as you said, and how bright they are and how much they know. Because if they're not too sharp and they don't really want to do anything except what they got to do for the day, and they're not really the kind of people that want to work with you and somewhat dismissive, you're in trouble and you should switch doctors either in that office or you may have to go to another office. And it's an issue because I wonder myself sometimes, if I want to switch doctors, do I go to someone else in that office? How is the doctor going to feel about it? What about when he or she is on call, next time? Because
Yeah.
all these doctors work together and it's worse in OBGYN because you kind of want to have your doctor deliver you when you're
Yeah.
pregnant. They never deliver you because there's 7 doctors that are
Right.
on call.
Exactly. Exactly.
So but that's what we're dealing with.
Yeah. What's interesting, doctor, is that, and what I wanted to ask you about is just what you were mentioning as far as switching doctors. So it's not necessarily going for a second opinion. Maybe it's just that for whatever reason, a patient is not jiving well with the doctor. Maybe it is a personality thing. And I know plenty of people who have said, well, yeah, should I stay with this group? They have my medical records, all of this, or should I go outside of this group and find another physician? Why do you think patients worry about that? And if we talk about patients as consumers, as shoppers of anything else, what do you think it is about this loyalty? I hear this a lot, loyalty to a physician that hasn't helped a patient, but the patient is really worried about moving on to another provider.
I mean, there probably a lot of things. The one thing is the personality of the patient. They may be a little timid. They may not want to do it. As I mentioned to you, I once had a very good doctor, but I couldn't deal with the office. I mean, they wouldn't call me back. They wouldn't, sometimes you need to get a report or something, and you can't. And they were so bad that I had to leave the office. And then I couldn't get my charts because they were so bad. So, but some of it is patients kind of feel this is their doctor. They want to kind of work with them. But at some point, the patient should say to themselves, even if the doctor is nice, if they're not coming up with an answer and you're still troubled and you can't get anywhere with them, they're not suggesting a consultation with somebody that knows more, either another intern. I mean, a lot of times you go to a general physician who may not have as much training as somebody in internal medicine. So you could say, I want a consultation with an intern. Or if you know it's your heart or your lungs or your kidneys or your brain, I want a consultation with a specialist in that area. And you should just ask for that. Um, and I don't know why patients don't. Some of it is their personality. Some of it is they don't want to hurt the doctor, but that shouldn't be a good valid read. I mean, your health is very important to you. Even if you think your health isn't being taken care of, you should still switch. And then if the next doctor is the same, then you might start thinking maybe it's you, not the
Right.
doctors.
Yep. Yep.
Although you could go to 2 bad doctors in a row too,
It's true,
you
and
never
and
know.
and I have done that, and luckily I found answers and some resolution. It almost sounds like physicians could use like the paralegal version of a researcher, so that you don't have time to be doing the research of what else could this be, to have an assistant or, like I said, the medical version of a paralegal to be looking up the possibilities.
We have that, we call them physician extenders, or they're also called mid-levels.
Oh, yeah. Mhm.
And that's either a nurse practitioner who is a nurse who goes on for a master's degree and has specialized training, sometimes in one area, but they have specialized training in nursing, and then sometimes it's more in one particular area, like they might be neurological or they might be, cardiac or something. And then there's something called physician's
Mm.
assistant.
Mhm.
And I actually got called by a relative last week who was looking for advice from me. And she's going back to school to get her college degree because of things that have slowed her down. Now she has a little baby on top of it. And she likes the health field, and she was thinking of nurse or nurse practitioner or um, a physician's assistant. And for her, physician's assistant is going to be better. And the reason is because it's shorter.
Right.
They're not, don't have to become a nurse first. I mean, nurse, and then nurse practitioner. That could take 6 years.
Yeah.
You could have to graduate and then become a nurse, and then, but physician's assistant, I guess you still have to get a bachelor's. But once you have a bachelor's, I think it's 2 years of PA school. And you don't know as much as a physician, but you know a lot. And you can help a physician. They always work with physicians, and they can see the patient first and present it to the physician. And the physician can say, I want you to look this up tonight, and so on. So I've had both of them working for me over the years, and they're very helpful. But it also depends on how bright they are and their
Right.
personalities.
Right. Yep. Yep.
I
And
mean,
it's not
some of them
something.
haven't been great, and
Yeah.
some of them have been like as good as me, as far as I'm concerned.
Right. And if they like doing research or things like that.
Yeah.
But doctor, before we do wrap up, I want to make sure that we get to an example that you gave me out of your practice about a patient. I believe you said she really thought that, like you said, we all know our bodies. We all know when something's not right. And I think you mentioned a story about a patient who thought she was dying, I think your words, and she pushed a little bit and
Don't give the
got to
answer.
something really good. So tell us about that.
So I may not have told you this. He was on a psychiatric ward in a hospital because she kept telling doctors, I'm dying. And whatever doctor she went to, they examined her. They didn't do enough. Let's put it that way.
Mhm.
So, and she was really so troubled by it, he ended up being put in a psychiatric ward. But it was a reasonable hospital, and it was a small ward. You could get medical care there as well. And the psychiatrist knew me and said, just before I totally treat this patient as a psychiatric patient, I want you to come in and evaluate this patient who thinks she's dying.
Oh,
And I did. And I asked her, all the so I started asking questions like an internist first before I got to the brain because I didn't know it was in the brain. And I said, "Are you having any trouble breathing? Have you having any chest pain?" And I listened to the patients back with my stethoscope and front with my stethoscope. And there was something funny going on in the lung. So I asked her if she had any trouble breathing. She said, "Well, yeah, a little bit."
mhm.
So we did a chest thing. You know how simple it is to do a chest X-ray? It takes about a minute, and it's often just normal. Although as you get on in age, they find little things, and it's usually not even anything. But I look at the chest area, there's something bad going on here.
Oh,
So I go to the radiologist, and they say, "Oh yeah, there's something going on here. We got to work this patient up." She had a hidden cancer deep down in her pelvic area, probably her ovary. When you have a hidden cancer like that, reasons that I don't know enough about, you get a little growth on a valve in your heart, and it can flip emboli to every organ in your body because it's coming from your heart.
oh,
It was going to her brain, it was going to her lung. He was dying. And it's just sort of lucky that they called me in consultation. I don't usually perform miracles, but, and in this case, I don't think whatever we were able to try to help the patient with even worked, because she was dying and we couldn't do much about it. But at least we knew that there was something wrong. We said to her, "You're right. You do have something major wrong with you, and we're going to work on you as much as we can and try to help you." So even a patient who says they're dying and people miss things and they are in fact dying,
Mhm.
you gotta be quite careful about that. And most doctors today would be okay. I don't know what happened. This was a long time ago. I've been in practice, as I say, for 52 years. This was a
Mhm.
long time ago, but that happens, and it's happened more than once.
Yeah,
So,
that's incredible. That since she was put in a psych unit, any sense, doctor, for how long she'd been seeing physicians trying to get answers?
probably a few months
Mm.
anyway. And then the last doctor probably said, "I want you to see a psychiatrist," which of course probably got her all shook up. And she went because she was looking for anything. And the doctor said, "Well, I want to put you in the hospital and give you very intensive therapy," which of course wouldn't have worked because it was psychotherapy, which is not what she needed. But that doctor was smart enough to call in a consultation. And luckily, I did the right thing. I said, "Well, let's start with a chest X-ray," and that was abnormal. So we knew there was something going on.
Wow. Gosh, Doctor Boy, she was lucky to
He was.
get you. Boy, oh boy.
He
Yeah, and for
was.
something so simple like a chest X-ray, but I'm sure her presentation didn't really warrant the need for a chest X-ray. I'm guessing, unless upon
Well, if you think you're dying, you don't usually do a chest X-ray,
yeah,
but
right, right,
you should
exactly.
start with a chest X-ray just to
Yes,
make sure it's
just
done.
the basics, right?
I'll leave you with the last thing. Everybody gets a CAT scan before if they go to a neurologist and there's any chance there's something wrong with the brain, they're going to end up with a CAT scan.
Mhm.
It's very rare that a neurologist won't do a scan. When I started out in medicine, there was no such thing as a CAT scan or an MRI scan.
Oh,
They
wow.
hadn't that's how old I am. They hadn't been invented yet. And when I was a resident at Mount Sinai for 3 years, I took care of hundreds of patients. I had to think. I had to talk to them. I had to do a careful neurological examination. I had to think about it. I could do a spinal tap. I could do a chest X-ray. There was something called an angiogram, which is an old type thing. We don't even do that much of anymore because we have CAT scans and MRI scans.
Mm.
So back in the old days, it was very difficult to figure out what's going on in the brain. Today, send that patient for a CT scan or an MRI
Yeah.
scan. But I try to talk my patients out of having a scan. They come to me and they say, don't I need a CAT scan, doc? What if I have a brain tumor? And I say to them, look, I think you have migraine. I don't think you have a brain tumor. Could you have a little tiny brain tumor that's there and have migraine? Maybe. What do you think about my treating you for migraine? And if you don't get better or you seem to be getting worse in some other way, we do a scan. Well, why don't you want me to have a scan? And here's the answer. Because if we do a scan, there's so that we could find a little something that means nothing.
Mhm.
And you're going to ask me, what is that? And what do we do about it? And then I'm going to read the report from the radiologist. And I have a son who's a radiologist, so I'm not against
Oh,
radiologists.
boy, I can only imagine what the holiday dinner conversation is like, doctor.
But we try to stay away from medicine. We try that he smokes the turkey and he cuts the turkey, and that's it on Thanksgiving. So anyway, radiologists aren't 100% sure. They say, we don't see anything abnormal, but there's this little white speck. We don't know what it shows for sure, but it could be an inflammation. It could be an infection. Consider this, which is a specialized kind of scan on top of that. And before you know it, the patient has a second scan. And these cost a lot of money.
Right.
Even if the patient doesn't pay for it, the system is paying for it. And then they'll say, well, maybe we need a spinal tap, and that might hurt a little bit. And then maybe we need to send you for a cardiac work. I mean, it goes on and on and on. And there's a term for that, which I won't bore you with the details of. But anyway, I try to talk my patients out of a scan and certainly out of a second scan because they come to me and they say, well, I had a scan 3 years ago and the doctors haven't figured out what's wrong. And I say, well, I don't think I'm going to figure it out from another scan. Let's hold off. But I have to be careful because if they get upset with me and they go across the street and the doctor says, well, we're going to do a CAT scan and something is found, then I'm in trouble.
Mm.
So I'm not cavalier about it. I just say to them, if I do a scan and something is found that's not quite right, we may have to do other tests. Are you ready for that? Or do you want me to treat you for what I think is wrong? So medicine's very tricky and there's no right answer to anything. And the best you can do is have a doctor that is thinking and wants to work with you and will listen to what we have to say and let you be part of the decision-making process. That's
Yeah.
really important.
Yeah. And as we know, sometimes the symptoms don't fit in that in that box with that pretty little bow, and you tie it up and say, this is what you have, and here's what we're going to do about it. It just doesn't work that way.
And if you go to AI or ask Dr. Google or now your iPhone is connected with AI, if you ask, be very cautious about what the answer is. It may be right on the mark and it may send you down a path that you don't want to go down. So
Right.
be careful because AI takes all the information available and puts it into a very big computer. And sometimes the information that goes in is not accurate. And therefore, you could get an answer that you might not like, oh, you definitely have MS. And you don't have MS, but you won't. First of all, it's the living daylights out of you. And then you go to 3 other doctors to find out that you don't have them.
Right.
And so you got to be careful. But I have nothing against AI. I use it myself. Just be cautious. My AI comes from my brain and my partner's brain. We didn't put the literature in there. We just did what we knew of the literature. So we know we're okay. But AI today takes that's what they do. They take volumes and volumes from textbooks. There's a lot of wrong information, believe it or not, in medical textbooks
Yeah. Or there's
or
so much
old
new
information.
information. Right. There's
Yeah.
information and it's still pulling from that.
Pulling from that.
Yeah.
So it's
Anything
not easy to be a patient or a doctor.
It is not, doctor. That is not. I remember way back when I was taking computer classes, I don't know, early in college, whatever it was, and garbage in, garbage out was the one of the
Yep.
first things that they taught us, which is true. But you are correct. It is not easy to be a patient. It is not easy to be a physician. All we can do is advocate for ourselves as patients and hopefully there's doctors who can reframe things a little bit in terms of how they approach patients who have these mystery symptoms or have been seeking a diagnosis. And I always say, keep pushing for answers. So thank you, Dr. Rapoport, again for
You're very
being with
welcome.
me today. And thank you, everyone, for listening. I am Laura Nozica, the host of the Desperate for a Diagnosis podcast. Stay well. And again, keep pushing for answers. Thanks, everyone. Oh my goodness, that's a wrap on another compelling story. Thanks for listening to the Desperate for a Diagnosis podcast. If you would like more information about today's guests or to find out more about Laura, go to desperateforadiagnosis.com. If you enjoyed the show, please subscribe, rate, and review the podcast on Apple Podcasts, Spotify, YouTube, or wherever you get your podcasts. You can also follow show updates and healthcare news on the podcast's Facebook page. If you would like to be a guest on the show, or if you have any questions, advice, or suggestions for our guests, please email me at lauramarie@desperateforadiagnosis.com. Please note, I am not a medical professional, nor am I affiliated with any healthcare, pharmaceutical, or device company. I am an entrepreneur and an independent market researcher focused on helping healthcare organizations better understand the patient perspective. The podcast is not meant to offer medical advice, but to merely share the stories and perspectives of podcast guests.